Good morning, everyone, and thank you for joining us today. My name is Megan Muller da Silva, and I'm a postdoctoral fellow at UBC. And today I'm joining from the unceded Comox territory, presently known as Courtenay. And I'd also like to introduce my colleague, Nicole Malcolmson, who is the community coordinator for the Kwiis and Niip project, and she's joining from unceded Taschat and Hupetchesut territory, also known as Port Alberni. So today we're going to be sharing about some of our experiences working on the Kwiis and Niip project, which is a Nuu-chah-nulth term for change. Specifically, we're going to be focusing on studying community-driven interventions to support emergency care in remote Indigenous communities.
Thanks for the introduction, Megan. Before we begin, I would like to give an acknowledgement to the 4 Nuu-chah-nulth communities that we are supporting. Those 4 communities are Kwiis, Heshkwiet, Ahousaht, and Kwiis. We are all Nuu-chah-nulth, and I'd like to share the meaning of Nuu-chah-nulth. The translation is people from all along the mountains and sea. I would also like the opportunity to introduce some of our project partners as well too. The partner nations we work with are Kwiis, Heshkwiet, Ahousaht, and Kwiis. Some of our partner organizations are Nuu-chah-nulth Tribal Council, First Nations Health Authority, Island Health, BC Emergency Network, UBC Department of Emergency Medicine, and BC Emergency Health Services. We're also partnered with the Utstakoo Society. That is a traditional healers who provide us guidance in our project.
So the Kwiis and Niip study addresses persisting gaps in emergency medicine in remote Indigenous communities. The project aims to design, implement, and evaluate community-driven interventions in emergency care in the 4 Nuu-chah-nulth nations Nicole mentioned. It builds on a prior needs assessment, which took place between 2018 and 2019, that involved an in-depth consultation process with Nuu-chah-nulth community members, local first responders, community leaders, nurses, physicians, elders, traditional healers, and it also brought medical students and external agencies into the conversation. So the illustration on this slide is an example of a graphic recording that took place during a community dialogue held in Tofino as part of the needs assessment. So the specific objectives of the project are, first of all, to develop a package of contextually appropriate emergency care improvements. Secondly, to implement those emergency care improvements. Thirdly, to then evaluate them. Fourth, to sustain these implemented improvements by building on partnerships and existing institutions. And lastly, to develop an adaptable model that could be of use for other remote Indigenous communities.
Through this process, we co-defined 4 priority areas for emergency care improvements: support for first responders, patient transport, communications, and community readiness. Subsequently, we added 2 overarching themes: primary care, cultural safety, anti-racism. First, I'll talk about the first responders, support and sustainability. Enhanced support for first responders will include access to real-time virtual emergency care support and post-incident debriefing processes. We are connecting dots and creating opportunities to standardized and tailored training opportunities. Training developed will be delivered in culturally safe ways and included in culturally relevant content. Patient transport. Our team will work with BC EHS to clarify and, when necessary, modify the changes of communication to authorize transport, increase availability and support of transport, and if necessary, redefine hospital referral patterns based on specific emergency. We will examine strategies to improve cultural safety and mitigate racial bias during the process of patient transfer of remote communities to hospitals. The focus for community readiness at this time is developing and producing a Nuu-chah-nulth-made CPR video for Indigenous people and health professionals. This will be filmed in April 2022. Communication. Our goal is to find a consistent provider for low barrier, high speed internet and cell service in the 4 communities to enhance emergency support and assistance for first responders and community members. Primary care, although previously listed, were a direct result of community discussions. They must be viewed in the context of nursing and physician support. Nursing support ranges from 3 hours per week to 24/7. Physician support ranges from nothing to 1 or 2 days per week. Support letters have been provided to Island Health for a primary care center for one of our communities and capital equipment as well. We're continuing our advocacy for virtual and in-person support with physicians. Cultural safety and anti-racism is one of our core values of the Kwiis project. Each member of the team is tasked with ensuring that the project is in alignment with the foundational commitments of cultural safety, anti-racism, and trauma-informed care. NTC values and protocols are main drivers besides the lost it again.
No worries. You want to do that whole segment one more time?
Yeah, I'll start from the top here. Cultural safety and anti-racism is one of our core values of the Kwiis project. Each member of the team is tasked with ensuring the project is in alignment with foundational commitments of cultural safety, anti-racism, and trauma-informed care. NTC values and protocols are main drivers besides the continual community engagement for this project.
In terms of the research side of this project, our approach combines the strengths of Nuu-chulnit knowledge alongside evidence-based practices from emergency medicine and implementation science. By engaging in meaningful consultation and co-designing solutions, the interventions are more locally relevant and sustainable. The study of these interventions involves a mixed methods approach incorporating quantitative analysis of incidents reports with key informant interviews, focus groups, ethnography, and community-based evaluation. The mix of these approaches ensures that our assessment of the interventions directly reflects the values and indicators determined by patients and community members. The Kwiis study expands the scope of patient-oriented research to encompass community-driven health research, reflecting the interrelation of patients, first responders, and health leaders in remote Indigenous communities. So the following presentation will outline our experiences and strategies around community-driven health research in 4 key areas of the research process. These include co-design, collaborative implementation, community-based evaluation, and Indigenous data sovereignty. Firstly, co-design in healthcare ensures that patients take an equal role in design and development, and that services are designed around patient experiences. Working in remote communities provides a little bit of a different context from working in hospital or clinical settings, and that's because it's important to bring the whole community to the table, as it's the community that pulls together in times of emergency in remote communities. So our team has integrated a co-design process by conducting a needs assessment, as mentioned, with the communities prior to starting the project. This needs assessment process identified priority areas and interventions. However, the interventions themselves have kind of changed and adapted along the way. So in this sense, the co-design element has been a bit more of an ad hoc process, responding to changing community needs and opportunities as they arise. For example, our team reached out to the Rural Coordination Center, BC, to connect with real-time virtual support programs, which connects doctors to healthcare providers in remote settings. In this case, the program that we're connecting with is referred to as the Rudy service. So this opportunity arose due to developments in virtual support care that have been so greatly needed throughout in terms of dealing with the COVID-19 pandemic. Yet our team felt that this program was well suited to meet a need that was actually identified through a difficult patient case that was shared with our team by a first responder. So in this particular case, the patient's outcomes would have been greatly improved if they had been directly transported to one of the 3 major stroke centers in BC. Connecting with a virtual doctor on hand at the incident may have improved the transfer process by ensuring that the patient was sent directly to the most appropriate facility. And there are countless other examples where virtual real-time support could have improved patient outcomes. So because a new opportunity met a need, we now have been focusing on connecting first responders with this real-time virtual support RUDI service. Additionally, collaborative implementation has helped to facilitate turning this goal into action.
Third, a step in the co-design process, deciding on interventions and putting them into action. We have a number of strategies to work collaboratively, and experience has shown this to be absolutely necessary for success. For example, the recruitment and hiring of first responder coordinators who live in communities has been instrumental in keeping communication channels open and connecting first responders and interested community members with resources and training. The RTVS RUDI service is another great example of collaborative implementation that was previously mentioned. Because the service was initially set up to support remote nursing stations, we had to think a little bit outside the box of some of the communities participating do not have full-time nursing stations. Another key issue that was identified was connectivity. What to do when Wi-Fi services are down. Each of the 4 communities has slightly different connectivity challenges, so it is a complex issue that we're still figuring out. However, collaborative implementation has been and continues to be necessary to work through these challenges. For example, a monthly meeting with first responders and RUDI doctors. This provides the excellent opportunity for doctors to learn more about the unique challenges faced by first responders in community and how to assist them better. And for the first responders to get a better sense of how to utilize the service and reach out to doctors to support them and their needs on a call.
In the Kwiis and Niip project, we aim to work alongside community to better understand how well these interventions are actually working. So for example, how should emergency health interventions be evaluated from a community-based or neutralist perspective? Addressing this question will involve collaboratively developing a series of workshops utilizing a community-based evaluation process. Following the culturally safe, anti-racist, and trauma-informed approach, which defines the Kwiis and Niip project, it becomes necessary to determine the impact of interventions from a service user and frontline perspective. As literature in the area of Indigenous community-based evaluation, specifically in emergency care, is presently lacking, indicators for evaluation must first be developed in collaboration with community partners. Additionally, working in collaboration with community is also a good way of recognizing the diverse needs and experiences in different Indigenous communities. So a community-based evaluation process can ensure that how the Kwiis and Niip interventions are evaluated will reflect what is most important to the communities who are the ones that are impacted by these interventions. This will involve co-designing the evaluation tools, piloting them, and recording and reflecting on the process. So as this is an area we are working towards in the near future, we would be interested to hear from the audience if there are others with experiences or advice in applying community-based evaluation processes.
Outside of the scope of co-design and patient-oriented research, yet we feel it's fundamental to community-driven research in an Indigenous context. For this reason, our partnership agreement with Toronto Tribal Council ensures that NTC is a data steward on behalf of the participating nations' data. Data sovereignty is a pressing issue that requires the research community to rectify the power imbalance by previous research methods. We need to be accountable to the normative practice of extracting data from Indigenous communities, often without any benefit of the research being returned to the community themselves. Indigenous communities and organizations should remain the owners of their data, and this is necessary to recognize self-governance in health services. We anticipate that upon completion of this project, the findings and evidence can be used to help inform the efforts of health leaders in the nations to manage emergency care systems from now and into the future.
So in closing, some of the overarching potential impacts of the Kwiis and Niip project are first and foremost to provide the 4 participating nations with a more effective first response system with access to remote help and rapid transportation when needed, also delivered with cultural safety and community bystander support. Additionally, the Kwiis and Niip project is contributing to strengthening capacity within and between Nuu-chah-nulth nations to continue advancing innovative change in first responder care, nation-led research, and data sovereignty. By organizing our work around the principles of co-design, collaborative implementation, community-based evaluation, and Indigenous data sovereignty, our goal is to catalyze long-lasting improvements in emergency care that are rooted in and responsive to community experiences and values. We also hope that our findings might be transferable to improving emergency medicine and care in other remote Indigenous communities across Canada.
Team with the Kwiis and Niip project. We would like to thank you for your time and following our presentation. Kwako, kwako.